recording. Thank you, lady. Colleagues, thank you so much for joining us today. We are very excited to reconnect. As you know, for the past month, we've decided to, we've decided to move the reference group calls on Ukraine and affected countries to a monthly time, also following the request of your request in our, when we've asked you how frequently and what type of meeting will be more useful, given that the coordination meetings are now happening very efficiently at country level with the technical working groups in Ukraine and in neighboring countries. So once more, for updates on what's happening at country level, what agencies are doing, we continue to encourage organizations to join the technical working groups and join those calls. What was seen as more useful from the reference group global level was to have more thematic content. So we had a survey, you will recall a few months ago already, about what some of those contents would be. The most voted content was children and their caregivers, and we hosted a call on children a month ago, more or less. The second most voted theme, which I'm very excited to have the opportunity to discuss today, is the mental health and well-being of older adults. So what we're going to have today is a very interesting session with some colleagues are going to bring some of their expertise, some of their information regarding the mental health and well-being of older adults in context of the Ukraine response. And we're going to have a small presentation, then a round table, and then I hope quite a lot of time for a Q&A, because I understand that these sessions can be especially useful for our audience to ask questions and ask for materials, and how can we work in this area that is so important. So I'm extremely excited to have today with us Katrin Seher from mental health specialist at WHO's Brain Health Unit and technical forum point for dementia. We have Marion Staton, Global Humanitarian Protection and MHPSS Advisor at HelpAge International. Lindsay Beckerman, Regional MHPSS and Protection Advisor at HelpAge International. I'm already apologizing for the mispronunciations. I'm not even going to try because, you know. We also have Irina Sheschenko, founder and director of Nesabutni, which is working almost from the beginning, giving us a lot of relevant information for the mapping. And we also have Natasa Todorovic, which is a health and care program manager of the Red Cross of Serbia. And she's actually also the president of the Gerontological Society of Serbia. So she also serves as a representative for Europe in the International Network for Prevention of Elder Abuse. So we have a lot of expertise, colleagues, today. And what I would definitely suggest is that you either share your questions as you have them in the chat, and I'll be paying attention and trying to pass them to our panelists, but also to ask them with your own voices and faces, if possible, for your video at the end in the Q&A. Having said all of that, it's my time to shut up and allow our colleagues to share their knowledge. So I'm going to pass over to Katrin for a small presentation on what is the impact of conflict and displacement on adults. Katrin, over to you.
Thank you so much. And Carmen, we now have you on record. So for all the mispronunciation of our names, we will hold you forever.
You got it. Forever and ever is there.
No. Thank you so much for bringing us all together. I really don't have too high expectations of this presentation. I really only want to set the scene with a few documents that I think will be helpful for us all to be cognizant of. I'm sure that many of them you've already seen, but I just wanted to give us a little bit of context to start or kickstart the conversation. You should now see the presentation in slide mode. Is that correct?
We see it, yes.
Yeah. Okay. Cool. Okay. So the first document I wanted to share or bring to our attention is really that report by the UN independent expert on the rights of older persons, pointing out that older people usually are invisible and very vulnerable in emergencies. And you all, having worked in that context, are very much aware of the fact. I've included the link to the report, which I feel is very strong, because it really makes the case for how older persons are less visible in emergencies, and what actions can be taken to increase the visibility and address their unique needs. The document talks about what potential reasons for this invisibility might be. Some of them are, and then also address the potential vulnerabilities that older adults bring to the table. So some of these vulnerabilities are intrinsic, in the sense that we all know with age do come certain disabilities, health conditions. But some of the vulnerabilities are also extrinsic, so a limited access to social security or pension, like higher rates of poverty and so on. And then there is a fair amount of systemic issues that actually create that invisibility. And that is, for example, the sheer fact that we don't necessarily collect information on the needs of older adults in emergency settings. So that's one part of the report and why it is important, and why it is so important. The other are some of the issues that it raises, to do with safety for older adults, the fact that they may lose social connection in emergencies, and I'm sure we'll hear a lot about this during this call, when it comes to, for example, decisions on whether or not to leave the country, to stay back, how that affects families and so on. And then, of course, the intrinsic vulnerabilities that I've already spoken about, how they affect the pure fact that someone may have disabilities or may be more frail, how that affects a person's access or availability or ability to access services, and then also the decision to flee to another country or be internally displaced. So if you haven't seen that report, I strongly recommend it. Roughly around the same time, Alzheimer's Disease International also came out with one report really highlighting or putting a spotlight on the issues that people specifically with dementia focus in humanitarian crises, and that really includes all sorts of emergencies that we can think of, and really pointing out that if you have an invisible disability such as cognitive impairment, it makes it so much harder to have your needs met at the best of times, but during crisis even more so. And then I think all these previous work really set the groundwork, or set the scene for us then when the COVID-19 pandemic hit, and we were all of a sudden all faced by a global pandemic, and the fact that older adults were particularly, again, vulnerable to not only contracting COVID-19, but then also risking highest mortality, issues of social isolation as a result of lockdowns and countrywide restrictions. You all know this, but what the change was back then was that for the first time we came together as the IASC MHPSS working group and created content specifically for older adults. First with the interim briefing note, just making some general recommendations of what to specifically consider, but then also the guidance on operational considerations with a chapter on older adults. And then last but not least, something that I'm really passionate and happy about, the toolkit, living with the times, as a resource for maintaining mental health and well-being for older adults, kind of like really offering something concrete that can be implemented at country level. So here, borrowing a slide from our HelpAge colleagues, and I'm sure they'll remind us of it and have much more in-depth data, but just as a reminder of why older people are potentially at risk is some of these I've already mentioned, the fact that they may be separated from their families. They do have, with age, come certain physical and cognitive disabilities that may prevent them from accessing services. We know that certain psychological conditions are more frequent in older adults, and then with comorbidities, for example, they may require more or ongoing medical attention and support through medicines, for example, or having nutritional needs. And then the safety issue I've already touched upon, but yeah, fact of elder abuse in humanitarian emergencies is, or in crisis time, is also a concern. Now, I've spoken a lot about older adults as a vulnerable group. I think one important message that we also need to remember is that older adults are, like we all, extremely diverse, and we cannot, just blanket statement consider all of them vulnerable per se. So it is important to really look at this at the individual level. And an important point that we were making in the COVID-19 documents was also to use the expertise and all the strength, the wisdom and the energy that older adults can bring, and incorporate that in our response at country level. So not just seeing them as a group that needs protection, but also as a big part of the community to actively engage in whatever responses that we plan. And then maybe on the specific topic of the call today, I wanted to share that joint statement on the situation of older people in Ukraine that was released just earlier in the month by the joint program on aging. And that really is kind of like the urgent call for the international community to recognize and shine a light on the special needs of older adults, and then leading or proposing concrete long-term action. So it's really, it advocates for strengthening the rights and safeguarding the rights of older men and women. But then it also is a call to the humanitarian and all other actors to pay that special attention. And I think, like the survey results that Carmen had mentioned, it shows that it is recognized by all of you as an important topic, and hence this technical conversation. I'm sure all of you will during the round table and your Q&A session afterwards share your thoughts. I'm really interested to hear from what the situation currently is on the ground, and hope we have a wonderful fruitful conversation and discussion. Thank you all.
Thank you so much, Catherine, for that presentation. It's a perfect introduction to the topic. And I would very much now have our colleagues complementing. So I'm going to do that thing of pinning our colleagues, starting with Natasha, and then of course, Marion as well. Lindsay, this helps a little bit with the with finding each other's, and Irina. There we are, our wonderful speakers today. Catherine, once again, thank you for that presentation. I just put in the chat the presentation that Catherine shared, and in there you can find also the links to those important documents and the call for action that has just been recently shared. As well in the specific context of Ukraine. And I think that would be maybe the first question to all of you, maybe to start with a common question. What we've just heard, what is the impact on older population of different emergencies? Why is it so important that we pay attention to it and we dedicate our resources and we minimize that increase in visibility, if you like. But I would like to ask you if you can complement what we just heard a bit more with the situation and these consequences for older adults in Ukraine and the affected countries, including, of course, the refugee response. So maybe I can start with Irina and yeah, to hear a couple of comments more on this regard.
Thank you, Carmen. You mean so I can just a comment, or I can tell my presentation?
First, maybe just to comment a little bit on what's the what do you see?
Yeah, sure. So yeah, I definitely agree with Catherine regarding that this category of people, and in particular people with dementia that we work with, are not visible, unfortunately. And in our case, this category, and I'm referring to people with dementia, they were not visible before the war as well. So we have even bigger problem. And actually, I can say that I feel that after the war started, somehow we managed to reach the ministries and raise the question. We managed to raise the question. And I can say that I feel that there is a positive dynamics now. So maybe if we keep on, this track with communication with all the stakeholders, we can use this unfortunately extremely bad case, but to highlight these people.
Yeah, thank you so much. And indeed, I think we will go back to you definitely later to hear more specifically about our older adults with dementia, which is, of course, a group at high risk. And thank you for those comments. I wonder, Lindsay, Marion, you've been helping HelpAge has been working in this emergency from the beginning. Can you comment on this presentation? What is it that you see that is affecting older adults in this emergency?
Thank you very much, and thank you very much for the opportunity to join this discussion. A lot of very important points were raised by Catherine in the previous presentation, especially in relation to the invisibility of older people. What we really need to remember is this crisis did not start in February, but it started in 2014. And indeed, HelpAge started work supporting older people in the east of the country around that time. 1 in 4 Ukrainians are over 60 years of age. The impact on older people in the east, where this originally started, has been immense. Something like 30% of the population is made up of older people. And older people were invisible and have continued to be invisible throughout the last 8 years, up until the recent escalation in the crisis. One of the many reports that HelpAge have brought out recently and over the last few years has highlighted where within the humanitarian sector, within the donor community, older people have been forgotten. And I'd be happy to share links to those reports later on, the missing millions, if not now, when, and so on. One of the, one of the first steps that anyone can do, and this was mentioned in the previous presentation, is consulting, engaging with older people, with and without disability in an accessible way, and ensuring that within the data we're collecting, the assessments we're doing, that we include that we disaggregate it by sex, age, and disability. That's really a simple step and the first important step. Older people will continue to be invisible until we actually reach out to them. All older people, and I think it was mentioned in the presentation, recognizing their diversity. So I will leave it for there now. Of course, there's lots of other points myself and Lindsay will share later on, but thank you.
Thank you so much, and some very important points on disaggregation of data, with something that we've continued to advocate for gender, for disability, for age. We still not perfect at doing it, and I think it's definitely a point that any organization focusing or not on a specific issue can do. So that's a very important point, and also thank you for reminding us that this been going for so long, and there's a lot to build on as well. So I would also I would like to ask Nataša if there's anything else that you would like to contribute in this initial putting on what's the situation, or how is it affecting the crisis to older adults?
Thank you, Carmen, and thank you, Catherine, to this very good presentation. I will just add two things, not to add, but to comment. What is very important in Catherine's presentation, conflict are complex situations by their very nature. For older person, they are complex and multi-affected situation due to a number of different factors. And what Catherine said, the risks that older person are exposed to in a conflict situation are various and different from person to person and from person to group due to the heterogeneous nature of the population. We speak about people who has from 60 to 105 years old. They are completely different, and they are not only frail older person. In many situations, they are person who can help us in conflict situation, in humanitarian situation, to help us to help to frail older person. That's one thing. And second thing, when we speak about mental health, with mental health, the fundamental problem in the mental health issue of older person tend to be normalized and overlooked in regular times. That's a huge problem. Depression and dementia are then just considered in the normal parts of the aging process, which they are not. And we always need to have that in mind when we speak about dementia and depression. They are not normal part of aging, but in sometimes they are part of aging, and we need to take care about this frail older person who has dementia or depression or anxiety on different mental health problems. Thank you.
Thank you so much, and I think that's a very important point, precisely because of the factors that you were mentioning. I would like to continue with you. That's okay, and ask you one specific question, because with your expertise and also very connected to the network for prevention of elder adults, I'm sure there are barriers that you've identified for accessing support. So can you comment on a little bit on those barriers, and which ones do we have to be paying attention to?
Okay, I will try with first one. There are at least two main issues to have in mind in situation of the conflict. The first is that there are still widespread ageist prejudices in the society, some of which even have a positive spin, that unfortunately are internalized even by many older persons themselves. Relief, because that's first step. relief response unfortunately relies on these ageist stereotypes and concept that older persons are seen as a more expectable or even less worthy than relief response to the other generation. The second issue has to do with architecture of relief response itself. The needs of older persons are met by different agencies who do not necessarily share or centralize important information, and then the relief effort does not have a reliable and updatable data on which to be based. We need more cooperation between agencies. Older persons, therefore, can easily fall to the crack with many of their specific needs left unmet in conflict period. We have in 2018, we have standards, relief and humanitarian efforts aimed at older person, and therefore we currently have humanitarian inclusion standards for older person and people with disability. But this needs to be applied with much more determination in all conflict situations and in emergency worldwide. Then over-reliance on digital technology, especially for communication, is another barrier and risk to older persons. It is true that many older persons use digital technology in their daily lives, but a non-trivial part of this population does not. And this may be because of lack of education, or because of not having access to the technology itself, but it means that a significant number of older persons may miss vital information or can be cut off from different kinds of support. And because of that, it's important always to ensure the use of different channel of communication in parallel as to avoid excluding of this older person who may need it more. And we are in Ukraine, see that older person will stay in the conflict zone more than younger person for a number of reasons that all have to do with ageist prejudices and social norms. Both the society and often older person themselves tend to think that this may, and then older person are left behind in conflict zone where the possibility of getting support is low. It should not be overlooked that one reason for this, that older persons often have stronger ties to their land, household, and they're afraid to start new life in a new country. So to preserve land or livestock, they may choose to stay in the conflict zone, and this expose themselves to immediate danger. And in non-emergency times, older persons failing through the cracks of formal support system, maybe family help them in conflict situation. During the war, they don't have formal, informal help, and that's crucial, important for them. And maybe we can think or plan in the future. I will say to you only one sentence is about another thing to have in mind is that in conflict in ex-Yugoslavia, younger refugees were the first to leave refugee camp, while older refugees stayed there for years or for the decade. We may make a prediction that this will be another serious risk of elder abuse, systematic elder abuse for older persons in the Ukraine conflict. We need to think about that because we have lesson learned. And sometimes we don't learn from previous conflict. Thank you.
Thank you so much, Natasha. And you're very right. We really hope each emergency is a learning for the following ones. That's not always the case. So thank you for that final point. As you were speaking, I couldn't help but reflecting on something that I did a lot when I was working in more specifically with disabilities, is how many of these barriers, when they are addressed, they are not for the benefit, in this case, of the older adults, they're for all of us. So how narrow-minded it is not to address barriers that we all will suffer in one way or another for different reasons. So it's not it's not something to be done just because there's people who need it right now. It's because all of us will definitely benefit from them. So thank you for highlighting those barriers, and thank you for this presentation. And I would like to maybe ask Marian and Lindsay, based on, we've talked about what are the difficulties, what is the impact, what are the barriers that Natasha was mentioning right now. And HelpAge has been working, as Marian was mentioning, for quite some time in this emergency. What are some of the things that can be done, that are being done? What are some of the things that HelpAge is doing in your programs in this emergency?
Thank you, Carmen, and thank you, colleagues, for sharing your perspectives and experience so far. So yeah, like Marian said, HelpAge has been working in Ukraine and in Moldova since before this conflict started. So we have the maybe advantage of building on our previous programming and have a lot of lessons learned as well. So some things we've been doing even before and are now adapting are providing psychosocial support via phone calls to older people, especially in the East, where maybe we can't reach them, maybe they're homebound. So we're providing check-in phone calls. We are also doing home visits where we can. So we have a team of staff and volunteers who provide home-based care. And then we're also setting up community safe spaces. So making sure that they're inclusive and accessible. And really, you know, within all of our programming, we take a community-based protection lens. So, oops.
Sorry about that. Please continue.
No worries. Yeah, so as well, cash for protection, multi-purpose cash, and really, you know, making sure that that gives older people the freedom to access whatever their needs are instead of kind of assuming their needs. So again, like Marian said, giving them the agency to make decisions and to decide what's important for them. Yeah, and then also providing assistive products for older people who might have disability, and really making sure to train staff and partners and even government partners on a psychosocial and a protection-focused lens in working with older people. So I don't know if Marian wants to add anything to that or not.
Thanks very much, Lindsay. Yes, I'll add a wee bit more. Another important focus area, not only in relation to ensuring that we collect disaggregated data, right? So not 60 plus, but let's get the cohorts in there, because as our colleague from the Red Cross has mentioned, the diversity of older people, but it's also recognizing the important role of caregivers and families where they are. Now, we know there's a huge percentage of older people that are living on their own, but we need to recognize the role of caregivers, families, and neighbors. And in the past, when we were working in the East, we had, mobilizing community volunteers, supporting with older people who are housebound, bedbound, with that home-based care. So not only are you looking at something like safe spaces, where in the past, older people within the community could come together. You had that peer support from older people who are resourceful, who are able to reach out to others, but at the same time, group support, sharing information in accessible ways is really, really important. I fully agree with our colleague from the Red Cross about this dependence on digital technology. This is a huge issue within the UK itself. That's not in a crisis like in Ukraine. And I do wonder, and I do worry that within the humanitarian sector, are we seeing this, you know, because of what we've gone through with COVID, over-reliance, or, you know, thinking that the only way to get information and messages out there safely and quickly is digitally. I'm not saying that older people cannot, you know, upskill and we cannot resource them, but it can't be the only way. The other thing I just wanted to add to what Lindsay was saying is we do rapid needs assessments. We've done a number of snapshot assessments in Moldova, in Poland, and in Ukraine, right at the start of the escalation of the crisis, reaching out to older people. We also then followed up with a more in-depth assessment from Ukraine itself, and this is with older people, and this is where you'll get the information about what their situation is, how they're coping or not coping. Are they on their own? Are they depending on others to, you know, to access basic services and needs? Because those things are extremely important as an impact on older people's mental health and well-being. And I do agree also with what was mentioned earlier about certain conditions, you know, mental health, mental well-being, such as depression being seen as perhaps a natural part of aging, which isn't correct. But at the same time, we do have to recognize certain resourcefulness. And if we can provide that wraparound support for older people in very different contexts, under fire, under shelling in the East at the moment, those that have been displaced 1,000 kilometers away in different parts of Ukraine, and then those that have moved out of the country, not a significantly big percentage of older people, my understanding from IOM reports and that, have left the country, which should be a flag to us about those who have left. But if we can provide and support and ensure their rights are met, that they have access to health services, pensions. Yeah, we never think of livelihoods in relation to older people because we don't think they need it. But if we think about the support they need holistically, advocate and work and link with other organizations, nationally and internationally, then we can ensure that their well-being, their psychosocial well-being is maintained and upheld. So thank you for that.
Thank you so much to both of you, to Lindsay and Marion. This is extremely relevant, so much that I'm already thinking about, but I think that the word agency keep coming up, and I think this is something that all of you are highlighting, and that is extremely important. I personally consider the issue of over technologization of the response important, not because as I was saying before, these solutions can be for the entire population. So we face the same issue when we go very technological in the COVID-19 response, but there's countries where for different reasons, the internet might be not there. Sometimes it's a matter of access. Sometimes it's a matter of, for example, being cut for limiting the connectivity of the population. So it's definitely important that we continue working in both technological, more technological and not responses. So those are some points that I'm already finding very fascinating. I'm sure in the Q&A we'll have some more comments and questions. And also you've mentioned a number of times, all of you, dementia. I think it's very important that we understand better what are the right responses when it comes to older adults living with dementia. And Irina, your organization has been doing extensive work in this area, and I wonder if you could share with us a little bit, what is it that you do? What is it that can be done to support adults with dementia?
Okay, thank you, Carmen. Actually, taking into consideration the current situation with dementia, a lot can be done. So we are in the initial state of addressing this topic. Just I would like to raise some numbers for us to understand the scope of the problem. So based on the Lancet journal and the Institute of Medical Research that provided the evaluation of the number of people with dementia in Ukraine, it's 651,000 people on average living with dementia in Ukraine now. The Institute of Gerontology in Ukraine, and here I see Dr. Viktor Holin, who is the director of the institute, provided the number of around 800,000 people living with dementia in Ukraine. The official data that is published is 62,000 people. So in Ukraine, dementia is not diagnosed. We do not have one register of dementia patients in Ukraine. So this is a huge problem. The awareness of dementia is extremely low. So as a consequence, we can see that there are no financed programs to support people with dementia on the governmental level. We do not have a national dementia plan. So these are all, big tasks that we started to address before the war, and I'm more than sure that we do not need to stop addressing them. And as I mentioned, we are now in a good contact with both ministries, and we have big stakeholders on board, and we would like to now not wait and to launch these programs. And they include all the spheres. So dementia is more social problem than medical problem for now, as it is not curable at the moment, but it requires all the possible stakeholders on board. But as we now discussing the question of the war and the effect of the war on people with dementia, so I can tell briefly what was our response at the NGO. So first of all, we saw that people started to address us with the request of the medication, because as the war started, the pharmacies were closed. So our chain of volunteers throughout the country were delivering the medications to these people. And later we managed to find big donors who helped us to ship big quantities. So we shipped already more than 3,000 tons of medications. And these are not only for dementia, but all the other problems that people have at this age. And why dementia in general? That I can say that 10% of people older than 65 have dementia, and with age it is getting more and more, this percent. And when the person is 95, half of the people aged 95 have dementia. So this is really a big, category of people, and it can happen to anybody. That is the main issue. And now the world is going towards the prevention of dementia. Medication, and we continue doing this. This is still a need for people. There is a big financial toll on the family regarding the war. So basic humanitarian needs like medications, and food, money, this is all, valid for now for these people. Another one was evacuation, and this is with the help of MSF. We are doing this program. We help to evacuate and transfer people from east of the country to more safer regions. One of the biggest needs that we see now is the lack of free beds for these people. The facilities that are currently in the social sphere, like gerontology, nursing homes, or second neurological internats, they are overcrowded, they're full, and there is a need on the highest level, on the ministry level, and we all agree on that there is no enough room for people who are not institutionalized, but who need a place to stay. So if maybe anybody of you can have experience how to, and this is a big challenge, but how to create like additional shelter, like temporary shelter for such people in a short term. With we understand this requires people, staff, medical staff, all the equipment. This is a big project, but this is I flag what is a need for elderly people, not only people with dementia. So for this category of people. So now volunteers are working a lot in different organizations to help these people. But if there is some system on board, maybe even for future crisis, that would be really helpful. We have discussed about the online and digital world. I agree that the coverage is not 100% for the country for sure, but that was one of the sources, you know, that when everybody is at home, there is no other way that we could reach the people. So we created a separate platform, which is called Nezabutni United, where we indicated all the possible help we, as an NGO, as our partners as well, provide. Which include mental health support for people with dementia and their relatives. This is group and individual sessions. Then free consultations of psychiatrists. Then free support with care consultations. And also how to get medications. So this is the platform that is currently being updated on the everyday basis. And also people who left abroad, who fled from Ukraine, can also have access from this platform. So we can place as much information, useful information as possible on this website. So if you see that any information can be, you think that you can share any useful information, we will be more than happy to place it on the web, on this website. Can I continue? Because I can, do I have more time or it's fine?
A couple of minutes more, of course, yes.
Yeah, okay, thank you. So, so I just wanted to tell more in details regarding the impact of on the mental health on our category of people that we work with, people with dementia. As the colleagues, as previous speakers mentioned, that it is very important to, when we speak about elderly people, to and their well-being, to think about the well-being of their carers, caregivers. And in terms of people with dementia, for us now working with the family, they are both equal. We cannot say which is more important, you know, when we tackle the problem. So we made a research, and in-depth research with 8 of our beneficiaries for like 1 hour call with very detailed questions, and we came to such outcome that 6 of 8 people confirmed that the state of people with dementia worsened during the course of the war, and 7 out of 8 people told of the caregivers told that their state as a caregivers worsened. As I'm speaking with, and my colleagues speak with a lot of our beneficiaries, before we called and had this research, we had the impression that all of them told that the state was really worsened. So if we speak about person with dementia, those who, and it depends on the stage, so we can briefly, so there are 3 stages of dementia, and starting from the cognitive like light cognitive you know changes, and then finishing with a physical disability. So when a person understands, and that is the feedback of our research, when a person understands regarding the war and the conflict, this gives an immediate effect on the state of the person. If they don't understand what is happening, we see the relatives told that they see less effect. So the 3 main factors that were raised by the relatives was that according to their belief worsened the state of the person with dementia are loud explosions and air alerts. constant. So we can imagine a person with dementia who needs, quiet, space here in these loud explosions. And even some of them told that when they see it on the screen of the TV once, that was enough to feel it, and then start to feel in this agitation and fear. Then on the second place was changes of routine. So people were at home, and when we speak about changes in routine, we understand that when there is an air alert, people have to go to the bomb shelter, or they have to go to the special place at the home, which for the person with dementia, it's difficult to explain why you have to go there. And those people who even manage somehow to go with the relatives in the bomb shelter, they told that this is the first and the last time they go there, because for them it is a nightmare to stay in this, for hours in this place. And here I just want to raise one important issue about the stigma that is currently in Ukraine, a big issue. People around don't understand what is happening with a person in dementia. The same when they are on the railway, for 24 hours going to the west of Ukraine, how to explain to, they feel shame, the relatives feel shame, they feel pain, and again, as we discussed, so nobody knows that this is an illness. They see so people. The dementia in Ukraine is something like a normal part of aging in Ukraine. So we have a big, work to do. And the last one is interruption of the medication, which was also one of the factors that people raised, explaining us regarding the worsening of the situation. And just a quick regarding the state of the caregivers. 2 out of 8 people told that they feel that they have depression. So 7 people told that they have that their state worsened during this time, and they feel. So when speaking to these people, we understand that this should be first, we have to work with relatives, we have to support the relatives, and then they have force to continue supporting it with extremely different circumstances to support the person with dementia. So thank you very much. Actually, I can speak more, so maybe if there are some questions, I will reply. Thank you.
Thank you so much, Irina. And indeed, there's so much to say, and this is so rich and useful. I'm trying to organize. So we have a hand from Natasha, and there's also a hand from Volodymyr and Ian. I would, if you don't mind, leave that for the Q&A. I just have one more question for all the panelists, and after that one question, we will move into the Q&A. But I just wanted to I have one more question for all of us, and I would like to actually bring something that you were mentioning, Irina, and that there's some comments in the chat about as well from Orest, which is the issue of access to beds or to services, as in institutionalization, as in places where the patients can stay. And of course, broadly in mental health, we keep on having this push for community-based alternatives. And I just want, so my general question to all of you panelists is to share with us, just to wrap up this very interesting discussion, maybe some best practices or ideas. There's some already shared in the chat, which are very fantastic. But if you have 1 or 2 best practices or programs or initiatives that you are aware with, and maybe a comment on a best practice related to this lack of beds, how can we go about this? Is there anything that comes to mind that could be a good contribution in this sense? Do we want to move towards primary healthcare type of support? Do we want to move to community healthcare? Are services recommended to be in one or another way from your expertise? So that one brilliant idea, one sharing with our participants on best practices, and maybe a comment on the issue of lack of beds or ideas to address this issue. So maybe we can start with Natasha.
Okay, thank you. if we speak about best practice, we in Red Cross of Serbia, we have telephone cycle. It's some kind of peer support that one person from Red Cross call one older person. First older person calls second older person, and you finish the cycle in 15 minutes. It's a low-tech helpline that we checking older person, checking other older person, is everything okay? Maybe it will be good for Ukraine too, because you build solidarity between older person. That's one thing. And another thing, I will just add something that it's any program of support of older person must be based on the knowledge that this is diverse population and that one size fit all solution will not work. Some older person are depressed, but most of them are not. Some may suffer from dementia, but not all. Some are digital excluded, but not all of them are. The design of the intervention should avoid imposing solution on older person and be based on listening to them, as they voice their need and concern. I think that in all situations, we need to listen older person what they exactly need. And always to think about heterogeneous groups they are. And very important is to adapt our relief and services to their needs. That's one.
Wonderful.
And I have a comment, not a question, for Irene, and about elder abuse. That people who suffer from dementia, they are in higher risk of elder abuse, about neglect and financial abuse especially. And we don't have any research about abuse when we speak about dementia. And risk of elder abuse in these settings is a burden of care of informal caregivers. And we need to help informal caregivers because we need to help them and to help people who are suffering from dementia. And because of that, we need to look older person and informal caregivers.
Brilliant. Thank you so much, Natasa. Those are extremely relevant points. I stick to agency of people with dementia and older people, diversity, and caregiver support. Those are very important points. And thank you for sharing that best practice. I like it, this peer-to-peer support. Marion, Lindsay, any best practice and comments?
I'd just like to say that I fully support all that my previous colleague listed. We had exactly the same in relation to recognizing the diversity of older people, recognizing the important role of caregivers and families, and that in support where they are, and in supporting them to continue to support older people. And that includes, even in something like cash, which there's a lot of talk about cash and cash for support, recognizing the additional costs that can be incurred because of increased, health needs and so on, to provide that support for the caregivers. So I fully support all that has been shared. The other best practice I would include is that with our colleagues and our staff and our volunteers or whatever, that we would share with them, that we would talk about, that we would impart to them the age, gender, and disability lens in their work, in that way to try to combat what one of our speakers talked about in relation to ageism. The barriers are, you know, attitudinal as well as architectural, as others were saying. And there was something else I was going to add, and that's escaped my mind. Oh yeah, we work together. We have Agent Disability Technical Working Group in Ukraine that has been, you know, up and running and working since, you know, the last 6 years. Nothing is perfect in life. Now's an opportunity to improve how we work together, the different organizations, both governmental and non-governmental. And one other point, I don't really have much to say in relation to access to beds or services and so on, but I think we need to recognize that this, you know, the hostilities, the conflict is still ongoing, right? And many of our colleagues, including within HelpAge, have been displaced, have family members that continue to live or are now living in parts of the country that are controlled by the Russian military. We had over 200 volunteers, community volunteers, living next to and near older people where they provided support and worked with them. It's a very, very fluid and different situation. Now, the line of no contact is expanding. So you will have older people who have left and are in the West. It's 1,000 kilometers away, facing different challenges. Yes, facing challenges, but it's very different than our older people who are still in the East, shelled, fired, bombed, no access to basic necessities, which has been ongoing since 2014, but increased terribly. So we have to be pragmatic and recognize these differences and the challenges for the older people who have left. There's a lot of work to do. There's a lot of work that needs to be continued, and we need to not forget older people with and without disabilities and their caregivers. So thank you again.
Brilliant. Thank you so much, Marion. Lindsay, any final comments or?
I think my colleagues said most of what I was going to bring up. So that was really, yeah, that was good to know. But I just 2 more quick points that I wanted to share that was on my mind as you all were speaking. One is like taking a holistic approach. So yeah, again, we don't have much to speak of about beds per se. I hope somebody else can share some more helpful thoughts, but meeting people where they're at. So it goes back to this idea of agency and meeting people where they're at. So if they want to stay in their homes or if they don't want to leave, going to them if possible, you know, home-based care with a holistic, multidisciplinary approach and a social work lens. As a social worker, I am a bit biased, but so yeah, making sure that they have access to health and psychosocial support, and also connecting to services. And I think one thing that we have seen as an issue is registering as an IDP or registering as a person with disabilities can be challenging. And so if possible, supporting older people to navigate that process. As I understand, if people are displaced, they have left some of those documents at home, and so they don't have the necessary official paperwork to do some of those things. And then just last thing is the significance of loneliness. So if somebody has been left behind or has traveled somewhere alone, just how much of an impact that has on someone's mental health. And so again, my colleagues already touched on it, but the importance of community and just bringing people together in this really difficult time. So thank you.
Thank you so much for those very important points as well. And last but not least, Irina, any final comments or points on your side?
Thank you. Yeah, it was very, very useful to hear all the thoughts. I wanted to say that we, as an organization, we are planning to launch work specifically in mental health support with people with dementia through online, thanks to the caregivers and person with dementia. This is something new for us. We have not done it before. So we are now investigating and finding best practices worldwide, how to best do it and build the program. So we are now working only with relatives with people with dementia through our psychologists, our online psychological groups, individual and group therapy. But now we want, because we feel we receive more and more requests from the families, can you do something for the person with dementia? And we know that there are actually a lot of therapies, non-medical therapies. So now we see that there are a lot what we see in the internet, but now we want to choose the best. What should we start with? And if you have any experiences in that, and I think we would do it now not only for people with dementia, but for, as Lindsay mentioned about the loneliness, that can be a way how to connect elderly, you know, and that I think they will be more or less the same for this age of for this age, the practices. So if you have any experience with that, please share it with us, and we as organization would be very happy to work together and to join our forces. Thank you very much.
Thank you so much, Irina. And what I'm going to suggest is that if you would like, either of you would like to share your email addresses in the chat, either to be contacted with this request, Irina, or if somebody has any further questions to you, then that's something that we can do. And we're going to move to the final part of this event, which is, I think, very interesting as well, and that's the comments and questions from the audience. So I'm going to give the word to Volodymyr Golik. Over to you.
Thank you very much. Just a couple of points. Some of them are a reflection to Irina comments. First of all, in terms of bed capacity. So we very well know that the Ukrainian health system has a huge bed capacity, which is higher than in every country of Europe in terms of number of beds per the specific population. So, and currently, this is a big problem, what to do further with these beds, how to repurpose these beds. And this is just a question, a reply for the question, where to find the beds. So from one side, we have a lot of sanatorias, which are supposed in some extent to be rehabilitation facilities, but we understand that this is not real rehabilitation, but this is beds from one side. From another side, this is a lot of some kind of veteran facilities, which are possibly may also be the source of bed, if we are talking about beds. So, and the second point is possibly this is a more strategic point than tactic point. So, currently, Ukrainian government is developing the recovery plan. So, and this recovery plan is also containing some positions and the section in terms of healthcare as well. And the additional situation next week, the Parliament of Ukraine will vote some additional legislation for the changing of the system of healthcare. So it will be the hospital areas and the cluster system of healthcare, and the main accent is put into the multi-profile hospitals in terms of inpatient beds, which is logical for the international context. And as well, it will be the possibility to have some beds if we need these beds. But the main issue and the main point I would like to stress on is the systemic point. So we don't have in the country the long-term care system as it is. And this is just the case for our situation. So we do have palliative care, but palliative care, and this is in fact end-of-life care. This is not long-term care. But this is just the case for initiate these activities on the government level to introduce and to start build the long-term care, which we all need. So this is not only for persons with dementia or for elderly persons, but also for the persons with some health conditions, very disabling health conditions, which cannot be involved in the high intensity rehabilitation, for instance. So this is just about long-term care. So we have a lot of possibilities and a lot of opportunities. The war is bad, but the war from another side is open a lot of opportunities to change, to move forward, to reconstruct the system, and just to be aware of this and to be involved, and to in some extent we are to be involved actually in the recovery plan. Thank you, and over.
Thank you so much for those contributions, and indeed looking forward to have the opportunity to improve systems after an emergency, which is something that we see often happening, at least an attention being brought to the key issues that a health, mental health, social health system may have. So thank you for those contributions. And I would like to then give the word to Ayan Sherif, who you were also mentioning in the chat, but I would still like to go over to you to hear your contribution now.
Thanks ever so much, Chair. And it's fantastic listening to all the support and knowledge that's on the line at the moment. So I feel quite humbled to be in this group of people. So lovely to see you all. It's just to say that we had a meeting with Irina in London on the South Bank, a very noisy South Bank, about a week and a half ago. And that was discussing sort of what the needs were of people living with dementia and their families in Ukraine. Following that meeting, we scribbled down a quick sort of what we thought maybe could be helpful. I chair 2 Prime Ministers groups here in the UK, and I also sit on with the Prime Minister on his challenge group for dementia. And I can say that those groups are clearly ready to swing into action should anybody feel that we have anything to offer. I hope we have. But we met with the Ukraine ministers last Thursday in Kyiv. One of our team did. And clearly everything that people are saying is it's around about rebuilding. But at this point of time, it's the capacity to do that on top of everything else that's going on. But my message to all of us is this isn't a one agency approach. I think if we can actually coordinate all our efforts together, we will bring change. If it's change that's required, I think the enthusiasm to do something is there. And we've been given a minister to be our main point of contact, the chief of staff I no idea what that means in sort of political terms, but that person is going to be our key road with the government. But when I look at Ukraine, I knew where it was because I worked for a long time in Moldova. But the size of it and the rural nature of Ukraine. And I chair the Prime Minister's Rural Dementia Group. And it throws up all its problems because you live in isolated communities, services, lack of connectivity, etc. So I think, you know, it's an exciting time. I will say that, but perhaps you wouldn't agree with me, but I think there's a lot of enthusiasm in country and an awful lot of skill. So it isn't about doing unto, it's about working with and whatever we can bring to the party. So I hope that we can take a coordinated approach to this, and I would look to maybe somebody from the group to do that, and we'll bring all our pressures and all the skills and knowledge that we've got to bear to help that process. Thank you.
Thank you so much for that contribution. And actually, just to go to the point that you were mentioning about coordinated response, we are joined today by several of the technical working group coordinators in several countries, and indeed that's one of the key messages is in whatever we do, let's try to bring a coordinated response. And just to note that this is indeed a very mental health and psychosocial support visible emergency. There's a central role that is being given to mental health and psychosocial support, including, of course, that of persons with dementia and older adults. So it's a good opportunity indeed, even though the situation is not as an emergency, something we don't wish to happen, but let's take that opportunity to build back better that we've mentioned so often. So going back to the issue of coordination, actually, I would like to now pass the microphone of such to Orest, who is actually supporting this coordination in Ukraine and also have a comment. So over to you, Orest.
Thank you very much. It's a big pleasure to be here with you. I'm not coordinating in Ukraine, only in one of the region, in Lviv Oblast.
In a little bit.
Because we established the subgroup of MHPSS, or Ukrainian group, and a lot of things was told very useful. But here in the region level, the needs are seen much more bigger and in much more bigger like areas or sizes. Yeah, so the war is still in place, and every day we still receiving the people who are evacuating. Especially last days, you heard about missiles attacks in different Ukrainian regions. So the people are going to the west, and I was co-organizing of psychomedical service at the railway station, which is still functioning, and every day we have people who are going to Lviv or who are going to the eastern part of Ukraine. And at the railway stations, the niche are seen much more wider than in region, for example, because people released from psychiatric hospital with mental health disorder disabilities are going home without money, without documentation, and we feel and see the needs in social support, which is lack. The same with people with dementia. But I would like to talk to you much more, maybe give me please 2 minutes just to explain the situation, because we accepting here and still accepting and accepted a lot of people with intellectual disabilities, dementias, mental health disorders. It was like personal, family evacuated, or institutions. You know Ukrainian context before the war. So this is high institutionalized mental health care, hospitals, internats, a lot of stigma. People are hidden at home or in institutions with dementias. So, and we were tried to transform this. So from the 2017 healthcare transforming processes. So we were in the development context, transformational context, and now war came to all over the country. So in this vulnerable situation to all over the country. So this is like double vulnerability. And now we are in a mixed context. One side is the humanitarian context, the other side we need to transform, to continue to transform situation. And in Lviv region, for example, we have one big psychiatric clinic, which has 600 beds. Now maybe 800 beds is fully occupied partially by psychiatric hospital from Kharkiv, for example, who evacuated to Lviv region. We also accepted some psychoneurological residential care homes or internats who went to existing internats. So it's like our crowded system existing here, and more internats from other regions are calling to Lviv Oblast asking about places. And in Lviv Oblast, we created this MHPSS working group, and fortunately, we have here representatives of the city and of the Oblast level, also of the region level. And now we visited every one of the rayons and asking about their needs and about their urgent needs. Mostly urgent needs are people with severe mental disorders, people with dementia who are in the shelters. And local actors, they don't know what to do with these people. Why? Administration should to make like quick responses. They decided to renew closed institution just to give roof and food. But we also understand that this is not an issue. And why, when I talk with all international organizations who are working here, that we need maybe not so much first psychological aid, but we need training to increase capacity of social workers, how to deal with people with dementia or mental health disorders at communities, to create places, assistant places, supported living places at communities, giving place of work, and also good human right oriented place of residential, of living for people with, but this is like huge amount of needs and of people. And using your coordination meeting, maybe these people would be very good to make this like coordinated process. And also thank you very much for Irena, because we know very good about Nezabutny work. And also Irena, there is working group in Ministry of Healthcare, interministerial working group with social care, healthcare people. You should be there just to lobbying the problems of older people with dementia. Thank you very much for possibility.
Thank you so much, Orest. It's wonderful to hear very directly from you, because then we can have a very clear picture of those needs. That comment to Irina to support the inter-ministerial group, and one more call to support all of us in this call, our colleagues in the different technical working groups. As Orest was mentioning, there's more than one group in Ukraine right now, and then we have all of the neighboring countries' technical working groups. So you can always access those contact informations through our communications and the newsletter of the reference group. Reach out to us if you need those contacts. Probably the final word, looking at the time, I see now another hand up. So I'm going to maybe ask Katrin to briefly comment or answer, and then Alexander.
No, I will really be quick. Orest has answered some of my question, because I was actually wanting to hear from the technical working groups in Ukraine, but also in the neighboring countries, on how or what is most useful. We all speak of coordination of efforts. We shared today's meeting, I think, was great in hearing, what all is happening, but what is or will be most helpful to the technical working groups, what can we concretely do to support hearing about the training needs, is something, I hear you loud and clear. And let's brainstorm more on how we can make this happen or support collectively. Over.
Brilliant. Yeah, I think that's a very good point. And I think one of the comments Alisa was making before having to go to another commitment was, let's bring this recording to the content of this session to the technical working group, so they can be an internal discussion precisely answering this question. What is it that is more needed? How can we support? And we will be glad to accumulate those questions and requests and feedback to this group as well. So thank you for that, Katrin. And I can go over to Alexander for final question or comment.
Thank you so much. It's a great pleasure to speak on high level and raise very important questions of our elderly persons. I'm working in Institute of Gerontology, and I'm chief of the Department of Social Gerontology and Lab of Occupational Rehabilitation. I always agree with all information been here, but we have a very, very important for you information that absolutely canceled all division, all our feelings to help our people. First, you don't know that you can't get medical insurance after 60 years in Ukraine. Absolutely. It's number one. Number two, that all our hostels, houses for people, medical care for people on pension, all in the hands of private non-government association, but they did that in exchange for the home or house of such elderly people. It's a very important thing. And another important thing is that no control, government control and non-government organization of this process, because most these deals is under the law. So there is no free housing for elderly people. And the next, but not least thing, that our healthcare ministry is a, alarm is crisis manager organization. every day, every year, every month, they have a special schedule according to government policy. For instance, COVID, war, something else, and all needs of elderly people is under the line maybe 25. So it's very difficult to really involve our healthcare ministry to support our elderly people. And it's, one more thing is very wild, that we have now no education and medical institution, universities, such professionals as geriatrics. So we have no official geriatrics. You know that it's necessary to establish, because needs of people on the pension and before is rather different, and all general practitioners are not always ready for this profession and to be geriatrics. This is a main idea. And last but not least, it's low income of pension, and great difference among the pensionists. In most countries, this difference about 10-12 times from minimum to maximum. In our country, it's up to 1,000, 10,000 times. So the minimum pension differ from the top pension in 1,000 times, you know. So this is the main thing that break and don't bridge gaps of all problems of the elderly people. Thank you.
Thank you so much, Alexander, for your contribution and final comments, because we've reached the end of this session. Thank you for those important remarks and for joining us today. And thank you so much to our dear panelists. Thank you, Catherine, for joining us. Thank you so much, Natasha and Irina, Marion and Lindsay, for your contributions, but also for all the questions and the comments from the others. We keep once more encouraging our colleagues to engage with this specific issue. If your agencies are working in any mental health and related programs in the response to Ukraine and affected countries, please consider, from as simple as doing a good, how do you say? The word is gone from my head, like using the disaggregation of data. It's something that you can do without necessarily engage actively in programming for older adults, if that's not along your lines, but you can disaggregate data. You can be sure to know the needs of older adults. A few words that have come throughout agency. To ask all the adults affected by this emergency, what is it that they need, what is it that we can do for them, and how. So let's acknowledge their own agency. Let's acknowledge the diversity. We have normally, we take the data from 0 to 2, to 2 to 4, 4 to, but then we put 60 plus. And that is a very large group to consider. So to take that into mind, we've also heard the importance to listen to the specific needs on the field right now. Reach out to our coordinators, because they know what the situation is, and is very diverse as well in different geographical areas of this crisis. And continue bringing up this important topic. We're going to share this recording, share the outcomes of this meeting, and through the technical working groups, hopefully continue to hear what is it that is needed. And organizations, we encourage you to do your best to bring those solutions. So thank you so much to all of the participants. Thank you, colleagues, and have a lovely rest of the day.
Thank you.
Thank you very much.
Thank you all. Thanks, Carmen.
Thank you all.
Thank you all.
Thanks, everyone.
Thank you.
Thank you.